And being the last speaker in the last session is not a very happy space to be in, but I'm grateful to the audience not only for its attention, but also the fair numbers. Being key stakeholders in healthcare, we are reminded and we realize every day that simply doing what we have been doing is no longer an option. We need to do things differently. We need to innovate, taking off from the last conclusion slide. And this topic today has three potential areas which can help enable change and change the way we deliver healthcare. The Indian healthcare industry, growing at a CAGR of 21%, is projected to be a $300 billion industry by 2020. The key growth drivers are a combination of demographics and economic factors. Not going into all the lists, I would actually touch upon only the pertinent points. India today is facing a demographic shift wherein currently it has a population of 60% in the younger age group. Add to this, it is expected to increase its geriatric population from 96 million today to 160 million 10 years from now. That is a huge potential base of patients to work on. It gives us a potential market for delivering not only predictive, preventive, curative, and geriatric healthcare. The diagnostic share, or 10% of the fraction of this healthcare industry, would be a projected 900 million by 2016. The growth drivers are majorly changing nature of disease. India today faces the challenge of caring for 1 billion. Along with this, it also has a challenge of a dual disease burden. This has been referred to earlier in the discussions, wherein the rising urban population in India is facing increased incidence of lifestyle diseases, majorly the cardiovascular diseases, diabetes, asthma, and cancer, which would account for an 11.5% prevalence by 2015. The rural India and the urban poor are still struggling with infectious diseases like tuberculosis, malaria, and dysentery. WHO estimates that by 2020, 2/3 of all deaths in India will be caused by chronic disease. So that is why we are talking about chronic disease. But why chronic disease management? Well, 10% of these individuals account for 70% of the healthcare spend. And of this, 33% expenses are for preventable conditions. Imagine the save we can make. 50% of inpatient spend of hospitals is due to chronic conditions. That is the burden of a non-communicable disease. There is a recent report from the Harvard School of Public Health which estimates that India would have a 126 trillion cost of healthcare to chronic disease alone from now through 2030. Now that is 35 times our annual healthcare spend. This is why chronic is definitely disproportionately expensive and needs to be managed. Well, this is also what is fueling a transformation in the healthcare industry, the way we change our care delivery model. The paradox is that we are still practicing acute care medicine in a world of chronic disease. And chronic diseases require ongoing care and management. They are not amenable to a one-shot fix. Today, we need to expand our healthcare services to incorporate and imbibe and include prevention and ongoing management for chronic diseases. Okay, with one nurse and half a doctor for 1,000 population in India today, the numbers and the figures just don't match. How do we deliver this healthcare? We need to engage and involve the patient and his immediate family for his self-monitoring. This can be enabled with technology today. IT as a key enabler. Much has been spoken about mHealth and eHealth in the previous session, so I won't go into those details. But what we can envision is that data transmission can happen from home monitoring devices, from blood pressure cuffs, from glucometers from scales directly to the personal health records to electronic medical records, where they are viewed, validated, authenticated by doctors and care providers. They can give alerts and action recommendations to the patients to take care and take charge of their health. This will help bring about a decrease in the acute interventions which are required for healthcare delivery. It may also bring about a decrease in the institutional care that would be required for these patients, freeing up the already scarce infrastructure as well as technical healthcare space. Forrester Research says and defines that market for healthcare unbound are technologies which are in, on, around the patient and free up the care from formal institutions. This research study divides this market segment into three main segments. One is the activities for daily living, that is the elder care, the chronic disease management, and thirdly, acute post-hospital monitoring. This report pegs this market at $34 billion by 2015, 80% of which would be contributed by chronic disease management. A key enabler of home monitoring and disease management is, of course, point-of-care technology. Technological advances are actually challenging the definition of POC. It is today defined as not only care at the bedside or anywhere else the patient might be, but also care where decisions are made by the caregiver, wherever the caregiver may be. POCT is also not just for glucose anymore. More and more tests are being waived by CLIA for addition into POCT testing. Glucose, coagulation, blood gas, chemistry, and cardiac markers just add on to the list of what we can bring about in point of care. So, need we ask what's driving the point of care testing market? It is obviously the advantage it has for the better turnaround time. It gives real-time decision-making results to the clinical provider, the clinical care and the physician, and in the ICUs for the critical care patients. This is a very attractive proposition to nursing and other healthcare personnel. It decentralizes patient testing, taking it away from infrastructure needs. Also, it would reduce possible overall healthcare costs by decreasing institutionalization of the patient and his hospital stay. The rapid diagnostic tests in this field of POCT do not require instrumentation or trained manpower. And this could also fill the gap which labs feel in filling up the vacancies with trained laboratory technicians. We all must remember that good therapeutics always follows good diagnostics. So there is a zero tolerance for medical errors. Hardware and technology is not enough. The future needs not only a QC or operator lockout system for these devices, or a dynamic patient verification at the device level to prevent sampling errors. It also requires the integration of this data into the laboratory information system where it can be validated. Because in the future, POCT would be a department of the laboratory working outside the premises of the laboratory, but managed from within. Now, absence of a symptom is not absence of disease. And absence of disease is not health. We need to change the way we treat. And the power of diagnostics lies in changing this focus of healthcare from treating sickness to promoting wellness. Lab tests not only help in screening diseases, and identifying acute and chronic conditions, they also help in risk stratification and in monitoring. Care management has to move from illness to wellness. This will only reverse what the trends we are watching in mortality and morbidity and manage the costs. This is what the current practice of a healthcare spend looks in a lifetime today. An investment early on in the diagnosis and prevention of diseases could actually give improved quality life and financial savings for our aging population. New medical technologies and genomics and aspects of personalized medicine and molecular diagnostics are another enablers and empowerers of the consumer. We may have a future where a 21-year-old could get a human genome done and predict whether he has risk for coronary vascular disease or cancer. He could use pharmacogenomics to actually decide which drugs would give him adverse effects. We have already seen the power of molecular diagnostics in acute myeloid leukemia, where identification of a translocation helps decide which subset of these patients would respond to ATRA, increasing their survival from a 0%, which was 40 years ago, to an 80% survival now. On another aspect, we see the power of diagnostics in KRAS testing in colon cancer patients, where a subset can decide who are KRAS positive, they would not respond to Erbitux. They need not be subjected to increased cost of treatment, which would be ineffective, and the side effects of the drug. Facilities of healthcare will no longer be providing all to all patients. They would specialize for targeted therapies and increase their competencies around targeted diseases. We may not be in the pink of health today, but yes, we are definitely at the threshold where there are immense possibilities in the delivery of healthcare and in diagnostics. Thank you.